All right, welcome everybody. My name is Dan Mersch. This is going to be January of 2026 BlockHeads. We're super excited to have everybody here. I am honored to present Dr. Santi Di Pietro, who recently came up with a wonderful article that we're going to talk about. He is an emergency medicine physician and scientist. He's internationally recognized for his regional analgesia program in the emergency department. He's an assistant professor of emergency medicine at the University of Pavia in San Matteo, Italy. Sorry, in Pavia, Italy, and has been driving force behind the Regional Anesthesia in Emergency Medicine Research Group, which focuses on real-world efforts very similar to the nerve registry that we've helped to run. That was recently highlighted in JAMA. Except he's pivoting from observational safety and utilization data to rigorously comparing techniques head to head to give best possible evidence. Most recently, his randomized control trial comparing the pericapsular nerve group block, or PENG block, with the fascia iliaca block for hip fractures tackled one of the most debated questions in the emergency department today. His research speaks directly to what the blockheads care about, which is translating ultrasound skills into better pain control, fewer opiates, and evidence-based decisions at the bedside. Dr. DiPietro, thank you so much for being here and welcome to Blockheads.
Thank you so much, Dan, for inviting me. It is my honor actually to be here tonight. Oh, actually, this afternoon, I should say. Um, Thanks a lot. I didn't expect such a comprehensive presentation, so I'll quickly move to the next slides. As you correctly said, I'm based in Pavia, which is a pretty nice place in northern Italy, not far from the Alps and the border with Switzerland. And I work at San Matteo Hospital, which is a tertiary referral center. However, I come from a much sunnier place, which is Sicily, and like most Sicilians, I have some family in the States, in Rochester, New York, and then my wife actually also has family in downtown Brooklyn, New York. So they don't look like them, although I mean, all right. So let's get started. Now, you certainly know these people. Some years ago, when I was a resident in 2017, 2018, I started to read some papers about nerve blocks in the ED, papers written by these people who you know very well. And I was actually, this was an eye-opening new thing for me. And these people genuinely inspired me to pursue a clinical and research interest in regional anesthesia application in the ED setting. This inspiration then became something more concrete. I set up a research group which is called Regional Anesthesia in Emergency Medicine, RIME, that essentially aims to set up and deliver high quality studies to increase our knowledge of regional anesthesia applications in the ED setting. And in parallel to the research activity, we also try to improve training. Please do consider that compared to the US context, emergency physicians really are starting now to approach nerve blocks. So we felt there was a lot to be done in terms of training and education. When I when I started considering to set up research and studies in this field, I thought, what are the urgent priorities, the urgent questions that need to be answered. So that seemed to me the most obvious one, comparing the new PENG block with the well-established fascia iliaca block. And that is where this trial comes from. As we all know, fascia iliaca block has been used for decades to control pain in hip fracture patients in the EDs. And its use is endorsed by several scientific societies in emergency medicine. And it is considered a key quality indicator that is also used in quality improvement projects at local level or national levels, for example, in the UK. In the UK, it is the most used block. More than 40,000 fascia iliaca blocks are performed every year in the UK. And you recently published this beautiful paper, which essentially also confirms that it is the most commonly deployed block in EDs, also in the US, or at least in the centers that were involved in this splendid project. However, recent research showed that actually we know that the analgesia that fascia iliaca block provides, it's good, it does its job, but it's not the best possible. And why? Well, probably this is due to the fact that often we have often the block fails to reach the very distal fibers that provide the hip capsule, in particular fibers from the obturator and accessory obturator nerve, and also distal fibers from the femoral nerve. Based on this sort of new anatomical knowledge that came out in 2016-17, a colleague from Canada developed in 2018 the pericapsular nerve group block, which essentially consists in injecting the local anesthetic underneath the psoas tendon on the top of the pelvic bone, essentially. This will cause, as you inject the local anesthetic there, essentially you see the psoas tendon being lifted up, and the local anesthetic spreads in a pericapsular fashion. And these results in an effective blockade of those distal fibers that I mentioned earlier in the previous slide. So that's the background. The PENG trial, I designed it in 2019, 2020, no, sorry, maybe a bit later. And then we actually recruited patients between 2022 and 2024. It took much longer than what we expected, as usual. But initially, we planned to run this trial as a multi-center trial. There was another ED in the UK that was meant to be part of the study, but then for some logistical reasons, they actually did not join us. So we had to complete the recruitment at our center. Based on previous evidence, we calculated a sample size of 64. If you look at all the PENG trials, pretty much they use the same sample size. And we compared PENG block performed with the levobupivacaine at the concentration you see there, compared to 30 ml of levobupivacaine with a slightly lower concentration. Now, you could, I'm sure there will be questions about this, and actually, there was a commentary paper to our trial where authors essentially said that we should have used the same concentration. But obviously, if you have two blocks that have by default different volumes to be used, if you use the same concentration, you're gonna end up with a different dose, whereas of the local anesthetic. Whereas if you use the identical dose, as we did, you're going to end up with a different concentration. So it's a kind of a conundrum, but we decided to opt for the same dose and instead having two slightly different concentrations. We included adult patients who had capacity to understand the scope of the study, to provide consent, and they all had a confirmed hip fracture, including all the neck of femur and intertrochanteric and paratrochanteric fractures. All the infratrochanteric or subtrochanteric fractures were excluded because PENG block is not indicated for those type of fractures. And we assessed pain with the VAS scale from 0 to 100, and pain was assessed dynamically with a passive gentle hip flexion of 15 degrees. We included only patients with moderate or severe pain. We excluded patients with known dementia or those who scored 2 or higher at the 480 test. This is the quick test that we use to detect possible dementia or cognitive impairment. We excluded the very obese one with BMI above 35. We excluded those with a body weight of below 40 because they would have a quite high risk of local anesthetic toxicity given the doses we were using. And then we excluded also periprosthetic fractures. Now, we assessed pain 5 times, starting before the block and then at 5, 15, 30, and 60 minutes after the block. So just for the first hour post-block. We're going to talk more about this choice later. And essentially, the primary outcome was the percentage of SPID. I will explain it into more details, but actually one number that gives us, that puts together all these 5 pain measurements. I will explain it into more details in the next slide. And then we used some cutoff of percentage of SPID, so 33%, and then 50%, which means essentially good analgesia or very good analgesia. Then we also observed the quantity of opioids and adverse events. Now, imagine you have these measurements of VAS. So from baseline 96 and then 61, 35, and so on and so forth. You can, of course, calculate pain intensity difference. So, for example, 35 and then 61 and so on. But then you have to multiply this pain intensity difference by the time, and then you sum them, and you get the SPID, the summed pain intensity difference. Then you can easily calculate the percentage compared to the maximum SPID, which is the hypothetical scenario in which patients went from pain whatever, 96, to 0, 0, 0, 0 at each time point, okay? This is the percentage of SPID. Why did we use this primary outcome? Because it's a brilliant strategy to put together multiple pain measurements over time. So you get just one number, and essentially this number, it's an approximation of the area under the curve for VAS scores. But it is a good approximation, but of course it's not a perfect approximation. But obviously we use the same strategy in both groups. So very quickly, we screened 92 patients. We recruited 32 in each group. The data I'm going to show you are with an intention to treat analysis. We had a few patients who were recruited to the PENG group, but eventually they did not receive it, and they scored 0 as having a percentage of SPID of 0. And these are the VAS scales of the two groups. The dotted line shows the VAS values over time for the PENG group. So we have a much better pain control over time and pain improvement with the PENG block as compared to the FIB. From these values, we derived the primary outcome, which is percentage of SPID, which was much higher in the PENG group compared to FIB, and this was statistically significant. Similarly, for these predefined cutoffs, we have many more patients in the PENG group who joined this value, which essentially means very good analgesia. And we even tried to use these 50% SPID, which means very good analgesia. And also in this case, many more in the PENG group had reached this cutoff. And you can see that the number needed to treat is very, very little. So that means that you need to treat only one, not even 2 patients with the new strategy to have essentially one more patient experiencing this outcome, having a very good analgesia. More patients in the FIB group needed the rescue analgesia for that 60 minutes post-block, but there were no significant difference in terms of the quantity of opioids. So jumping to the conclusions, based on this study is in line with other trials that have been done that essentially say PENG block works better than FIB in terms of providing analgesia to hip fracture patient. I like to design randomized trials because I like to try to give definite answers to research questions. But you may ask, well, is this a definite answer? So should we definitely leave behind FIB and just use PENG? Well, I think the answer is no. Or actually, I think the evidence is yes, we should use PENG, but there is more research probably to be done, because this is only a single center study which limits the generalizability of our findings. And there are also other information that we need to get from future research in terms of safety. For instance, there is a UK guideline classifying PENG as a deep block, considering it more dangerous than FIB, although this statement is not evidence-based. But I think that in general, we need larger trials to see whether actually they are equally safe and whether and to confirm that whether PENG block is more effective than FIB. Thank you so much, and I'm more than happy to answer any question or comment.
Awesome. Just absolutely fantastic work. Thank you so much for doing this really
Thank you.
great and we know onerous work, and the dropout of the other site and these things are complications that we've seen in other big trials. So thank you again so much for this great work. So I'm going to open it up to the floor for questions and conversation.
Two questions. Hi, I'm Kat Vlasica.
Hi, Catherine.
Great study, by the way. I
Thanks.
loved seeing this head-to-head done in the emergency department. So two questions. I can understand taking out the patients under 40 kilograms for the concern of last. What was the reasoning for the exclusion for higher BMI patients? And then second question is, what approach did you use to the fascia iliaca? Did you use suprainguinal, infrainguinal? What was
Th-
your method
Thanks a
there?
lot for this question. So, first question, BMI wise, I kind of expected that. I expected some comment about BMI because, of course, we see different population and probably you see patients with a higher BMI compared to us. Good question. So when we started this before we started this study, I went to theater, and thanks to the help of some colleagues in anesthesia, I kind of approached myself to the to PEG block. When we started the recruitment, probably had done 12 to 15 PEG blocks. So I felt I was kind of confident. But then we had also my colleagues. In total, we had 6 doctors performing procedures in this block, in this study. Okay, so I was concerned that having including patient with a higher BMI would have complicated would have introduced how can I say, would have complicated things too much, especially for other colleagues who had lower experience compared to me. And I felt this would have kind of jeopardized the study findings. But to be honest with you, we never met anyone with that above 35 of BMI. Actually,
Lucky you.
there was one, most of our elderly patients with hip fracture, they have a BMI of like 19, 20.
Wow.
21. So they are very lean and cachectic. So I think adding that inclusion or exclusion criteria actually didn't change much. And second question, we used infrainguinal fascia iliaca block. This was also a comment published as a commentary to our paper, or the authors said essentially we should have used the suprainguinal fib because it works better. And we know it works better. The problem is we wanted to be pragmatic, and those 6 doctors in my ED, or the other 5 in my ED doing FIB, they were skilled in infrainguinal FIB, and also in the UK the standard approach is infrainguinal FIB. So having in mind to include also UK center, we wanted to be pragmatic, and we kind of disclosed this as a limitation in the paper.
Right. Yeah, that's definitely a different approach and kind of harder to take a whole bunch of learners and teach them that. But thank you for this. This is great.
Thanks.
Dr. Pietro, that was a great presentation and really great paper
Thank you.
and fantastic research.
Appreciate it.
I have a question about, I think we've evolved to think about using fascia iliaca when we have, especially elderly patients who are having a lot of muscle spasm associated with their fracture. The idea that the PENG is more motor sparing versus the fascia iliaca, and that seems to have been like subjectively an effective dichotomy, that the patients who have the muscle spasm seem to do really well with the motor block, and those that otherwise we use a PENG block. And was wondering whether there was any documentation or recognition that that there was a difference in spasm or different levels of cause of pain from the fracture in your data at all.
Thanks a lot. I that's a brilliant question. I actually never thought in the way you put it. about this issue. So our data did not explore this kind of aspect, but in general, I think that so the motor sparing thing or advantage of PENG block is probably overrated for a very simple reason. It is very useful in the immediate postoperative setting, because you want to start rehabilitative physiotherapy. You want to have patients back on their feet as soon as possible. So that's not our cup of tea. And also, I'm not sure what's the time from admission to the hospital to surgery in your hospitals, but we are experiencing probably 24 to 36 hours of delay. So ideally, we should operate them within 24 to 48 hours, but we struggle to achieve that. In the UK, likewise, many patients wait 36 hours or even longer than that. So having a motor sparing block or not motor sparing block has no impact, I think, in general, from our perspective. Going back to what you said, certainly muscle spasm can contribute to pain, but I think that muscle spasm is it's both a consequence of the fracture, but also a consequence of pain itself. So I think if we stick to the main goal of treating as much as possible pain, I think that also that side of the coin is also kind of covered, possibly, but I may be wrong, of course. But of course, there are also other strategies you could use to treat muscle spasm. If you think that your patient specifically has an exaggerated muscle spasm, you may consider using benzos or something else to control that. I don't know. What do you think about it?
Yeah, no, it's great points. And again, this has been subjective, where it's mostly we're observing quad spasms, and that when they resolve, that seems to be helpful, and we're trying intention to avoid using benzos or opiates as we can with elderly patients.
Yeah, of course.
Great points.
I was thinking about tiny little doses, like a pinch of
Yep.
of benzos, but yeah, of course, we should try to avoid them.
Hey, thank you. This is Arun. Thank you so much for joining, and thank you for doing this great work.
Hi.
It's interesting. When I started doing PENG blocks years back, I always subjectively felt they were not as good as my fascia iliacas, and I started reading the literature in anesthesia and PENG and I still fought it. So this is great, because this again told me that I'm wrong, and that really understanding the fact that when you look at patients, you have to do it in a way that's a little bit objective and not just subjective, that my blocks work for this and that. So I think it's really important that this is becoming the standard in the way that we do our research papers. And it's really important that we all kind of model some of your work and do this for other blocks that we're doing in the ED. I think this is fantastic. Thank you so much.
Thank you so much. And can I ask you something, Arun, actually? Do you think that, compared to when you started doing PENG, of course, now we have a much more experience with this block. Do you think that now your PENG blocks are better? So do you think that it was also a matter of learning curve?
Yeah, maybe that may be true. I think it's what you realize. Pain is a very subjective endpoint, but we also do blocks, walk away, and come back. And I think that my return visit was based on my subjectivity. So I think my skills were okay. I think. I don't think it's changed that much, because I think it's a fairly simple block. I do think that my evaluation of my own skills was wrong. So I would come back and inappropriately think that I did a good job. So I think this is all soft, but the point being that either one of these blocks work for multimodal pain control. PENG may be a little better. And that's what I take from it. And now there's EM data showing this, which is great. So hopefully that answers your question.
Yeah, absolutely. Agreed.
Thank you so much.
Thanks a lot. I mean, also throughout the recruitment process, we had a few PENG block that actually failed. There was one patient, I did that block, a patient who had a BMI of 34, just below the threshold, and I personally struggled with that. And eventually I completed the block, but I knew it wouldn't work, and actually it failed completely. So I think it's okay. It can happen.
Yeah,
It
of
can also
course.
happen with the fascia iliaca. But the good thing is that we analyze data with intention to treat. So those cases where PENG block could not be performed were considered as PENG block giving a SPID of 0. So we kind of penalized that, and still putting all data together, PENG block seems to work better.
Great. Thank you so much.
Thanks
Thank
a
you for
lot.
coming on too. Really appreciate it.
My pleasure.
There was a question in the comments about was there any trend toward efficacy based on location? Was it more effective the higher you were in the joint?
Sorry, just give me 1 second. I stopped the presentation and I'm going now to see the chat.
Dover specifically said, did you break down the femoral neck versus intertrochanteric fracture results?
So yes, we published a secondary paper, which I'm more than happy to share with you via email. I could send it to Dan, which is a secondary exploratory analysis where we compared the intracapsular fractures and the extracapsular fractures, so the intertrochanteric ones. And essentially, we show, although beware, this is just an exploratory analysis, we show that also that in both groups it works. It works in a similar way. So probably there are no differences because the local anesthetic not only spreads to the pericapsular area, but some of it also spreads further down to the trochanteric area. So part of the action can also be attributed to some a sort of hematoma block, essentially. And then, sorry, there was another question. All PENG were done by one provider, the FIB. No, so all blocks were done by 6 doctors, including myself. This might seem to you a small number, and it is actually a small number. We have something like 22 to 23 consultants plus many more trainees. Problem is that, again, in Italy, we are much behind compared to you guys in terms of nerve blocks and regional anesthesia. So essentially, I had to limit recruitment to those who had the skills, and it was just a small group. And then, did you potentially prove that you are better than your colleagues? Thanks for this question. I don't know. No, I didn't explore that. Oh yeah, I see the publication there. Is that the secondary analysis that you shared?
I believe so. I'll just take over the share real quick. This is kind of what it looks like. Is this correct?
Give me 1 second. Yes, correct. That's the
Great.
one.
Okay,
Yes.
great. All right, so we'll send that out with the meeting notes. So I want to say thank you so much for coming out with us. I know it's late at night there; it's probably 10 o'clock p.m. So we really appreciate your time with us.
All
It's
right.
great research. It is a perfect complement to the nerve registry. I'm just so glad that all of us throughout the world are working on just delivering better pain management and better outcomes to our patients. So, Dr.
Thank you so much
Di
once
Pietro.
again for inviting me. It was an honor for me to speak in front of this audience. And I just hope this is a starting point for future collaborations between your group of BlockHeads and my research group. I mean, in particular, I would love to potentially run studies together because I think that my gut feeling is that there is a lot of interest on the topic worldwide, also in low and middle income countries. But I think what we need to change, to go a bit further is to deliver international studies, large
Awesome.
multinational randomized trials. I think that's the direction we should aim for.
Wonderful. All right. Well, thank you so much again for your time. And thank you, everybody, for coming out. We'll send out a summary and some more resources for everybody. For now, have a great rest of your day. Thank you.
Thank you.
Thanks so much.